So any doubts? Dr. Wafa, Dr. Nicholas, Dr. Kishore, Dr. Rima. Anyone, any doubts from the previous class? No
Good
doubts?
afternoon.
Yes, good. Yeah, it's good evening in our time
Good
zone.
evening. I was time
Yes.
afternoon. That's fine. Good to have you
Yeah,
again.
no worries.
Not as such as doubt, some
Yes, yes.
challenge on the virtual interaction is some many picture ultrasound for many of us is the first time we're acquainted with the ultrasound. Would have liked to have them labeled some information. We just see one, maybe they say this position is for maybe for let's say for such tendon, but there are many structures on the same picture. So for someone who's not familiar like myself, I'm sorry to say that it's a bit tricky to know if they could label all with some
Okay.
signs. Say when scrolling, you move from this structure to another one, it will be stick in our mind. So that's what I want to suggest, if possible.
Okay, today you go through when I'm taking the class. Okay. If you find that this is fine, how I am annotating and all, then it is fine. Okay. Then we will
Thank
go
you.
ahead in the same manner, right? So every
Thank you.
structure, how we are moving the probe, I do understand because like for person who is learning ultrasound for the first time, it becomes difficult. How are we moving the probe? So today you go through, you just listen to the class. And if you are really, you are able to engulf what exactly I'm teaching you. So the later on in all the classes, we will be just going in the same manner. Okay.
Thank you so much, ma'am.
Okay. Any more doubts? Or if no doubts, I'll start today's class.
Excuse me.
Yes.
I have a question
Yes.
regarding shoulder ultrasound. I have had a patient who has like trauma, whiplash injury to the cervical spine, and she suffered from like myofascial pain syndrome in the upper trapezius fibers. But she did an MRI for her left shoulder since she has like pain on it with some restriction in the movement, and the MRI come as signs of distorted superior glenoid labrum with tear and associated with thickened of the superior and middle glenohumeral ligament. Any intervention can be done from our side regarding these findings in the MRI of the shoulder. Thank you.
Okay. Have you examined the patient?
I saw her only for a procedure examined by my colleague,
Okay.
and it was planned for a trigger point injection only in the first step.
Okay, I'll tell you one thing. For myofascial pain syndrome, the recent approach is going for an interfacial hydrodissection. That is the first thing, rather than going for a trigger point injection. Second thing, after an injury, if you have not examined the patient or your colleagues have examined, I would really suggest you share the examination finding, because sometimes what happens now, we are like in MRI, you are going to see so many things, but not necessarily those things are the one who are the pain generators. You got my point? Like you are telling me there is a thickening of SGHL, there is a thickening of IGHL. So this is more suggestive towards the adhesive capsulitis, right? And if at the same time she's having a restriction of the her motion, all the shoulder movements, it is more suggestive of adhesive capsulitis, where you go for the hydrodilatation of the shoulder joint. But at the same time, when you are telling me that you are seeing a labral tear, I'm very much concerned about the bicipito labral complex, right? Because if it's a superior labral tear, then she might be having some problem with her biceps tendon as well. And when it comes to labral pathologies, it should always be treated surgically, depending on what exactly is the grade of the labrum, how it is, where exactly is the tear. That is very much important for us to understand. So if possible, can you share the MRI findings, or can you share the examination, so that, we will have a better, idea about the patient, I think. And if you go with the treatment right now, because the labral, there is many people have started injecting PRP also into the labrum, right? And they are just claiming that it is going to give a very good result. But what I would suggest you is to find out whether the long head of the biceps is involved along with it or not, or whether you have a Hill-Sachs lesion or you have a Bankart lesion. That also we need to know how exactly the lesions they are. Just like that, a labral tear is a very vague term because we have so many classification of it. You got it?
Yeah, but according to the MRI, the biceps tendon is within normal in signal
It is
position
fine.
and
If she is having only the thickening of this, and if everything is perfectly fine, then you can go for a hydrodilatation. You can use two approaches. There are two approaches. One is like if you are a beginner, I would suggest you go with the posterior glenohumeral joint. You know how you are seeing the posterior glenohumeral joint. There you can inject 40 to 60 ml, right? But when you are going through the rotator cuff interval, the amount should be limited to 20 to 30 ml. You are not supposed to go beyond that. And as a beginner, it is always easy. It is, not very complicated to go through the posterior joint, like glenohumeral joint technique. That is the most simplest which you can go for right now with the normal saline. That's all. Nothing you have to do.
yeah, thank you very much. I got it.
Got it?
Thank you.
Yeah.
Dr. Wafa actually told, like sent the MRI report also. I'm just sharing, just a minute.
You send me in the WhatsApp. I will see there. Can we?
Yes. Thank you very
Not,
much.
not
Dr.
this MRI report, the pictures, the pictures.
Pictures are not there.
No, this report, no. I just want to see the pictures. Okay.
No, I don't have the
okay.
pictures. I'm sorry, I don't have the picture. Only the MRI. Only the MRI report.
Okay. Because that is
Yeah.
going to give a clarity about this labral and biceps.
Actually, labral tear should be diagnosed by MRI, and for our pain interventions, labral tear is not a very what should I say, rewarding phenomenon. I mean, rewarding condition where if we inject, we may not get that much of good result. That's what. So I told her that. Yeah.
Yeah, thank you very much, Dr. Shinmoy.
Okay.
Any more questions? No questions? Okay. So I'll be taking this elbow joint. I think my screen is visible.
Yes, yes.
Okay. And I'm audible, right?
Yes.
So I will be talking only about the anterior and the medial side, and the posterior and the lateral side will be taken either by Dr. Chinmoy or Dr. Debjyoti. So what I always suggest is whenever you want to scan any joint, take it any joint, be very confident with the bones, because these bones are really going to help you in identifying so many structures, right? It is not only in C-arm where your bone is a friend. If you see the ultrasound also, bone is a, I should say, true friend of yours. It's not going to ditch you at any point of time, right? Until unless there is an anomaly associated with it. So when you say elbow joint, we basically talk about an articulation between the distal end of the humerus and the upper end of the radius and ulna. So carefully watch this distal end of the humerus. What exactly are we looking at? So if I see this distal end, it is a straight thing, and then I have a concave depression here, right? And I have another concave depression here. So these are two fossas, right? So there is two fossas, the concave shape depressions. Now these are present on the anterior aspect of the distal end of the humerus, right? Now this rounded one is your capitulum. And what you are seeing here, something like this. This is the trochlea. We do have trochleocapitular groove, which is this one, right? So you have a capitulum, which is a rounded one, and then you have trochlea, which is a V-shaped structure. Fine. Now, if you see here, there is a protrusion, something which is protruding out, right? So this is your medial epicondyle. And this medial epicondyle, then this is the downward slope, right? Now, if you look at the upper end of the ulna, you have something which is going up like this. Now, this is, a pointing, something which is pointing like this, or I should say inverted V, where this point is the vertex of these two line segments, right? So this is your coronoid process. And what you are seeing here, that is the radial notch, which will be articulating with the head of the radius to form the superior, this radio-ulnar joint, okay? And this is the head of the radius, right? Okay. Now, when you see the, I should say the upper end of the ulna, so this upper end, this whole, we are going to call it as trochlear notch, right? So this trochlear notch will be fitting, it's just like this. You can imagine it like a C-shaped structure, fine? If you see it from the lateral aspect, it is going to be a C-shaped thing, fine? Where your trochlea of this humerus will be coming and will be getting articulated, right? So this is trochlear notch. Now the upper portion of it, this one, that is your olecranon process. This is sublime tubercle, a bony thing which is present here on the medial aspect of your coronoid process. And this one is the ulnar tuberosity, where the biceps brachialis tendon will be getting inserted on. And this is your radial tuberosity, a rough area where the biceps tendon, the distal biceps tendon will be getting its insertion. So quickly, we will just revise it once again, right? So medial epicondyle, these are two fossas. So this fossa is, we are going to call it as coronoid fossa, because your coronoid will be getting in here when you are going to flex the elbow. This is radial fossa because the radial head will be getting inside it, right? So you have a capitulum, then you have a trochlea. So this is the rounded one is the capitulum. This is trochlea. This one is the radial head. This is the coronoid process, medial epicondyle. And then you have the sublime tubercle, which is this one, ulnar tuberosity, radial tuberosity, trochlear notch, and this is the olecranon process. Fine. So this you should know when you are looking at the bone. Now, this articulating end will be covered by then the synovial membrane. Okay, so this is the synovial membrane, which is covering it from the anterior aspect, and this is from the posterior aspect. Then after this, you're going to have the capsule of the elbow joint. So this is the capsule of the elbow joint. Again, this will be just, I should say very much closely attached to the synovial membrane. And we do have capsular thickenings on the medial and the lateral side. So on the medial sides, I'll be just coming in a while, and the lateral and the posterior will be covered by in the next class, I should say. Now, when it comes to muscle, this is my rule. I always say this rule, and it is being published in our book also. So it's a very easy way to remember what exactly are the structures which are present on the anterior elbow. Super duper easy. If you will listen it very closely when I'll be showing you, you will remember it in this class itself, right? So just remember 3-2-1-1 rule. Now, what is this 3-2-1-1 rule? When you are looking at the anterior aspect, there are three muscles which you need to remember. What are the three muscles? So if I have to go from the lateral side to the medial side, I have the brachioradialis, that is the number 1 muscle. In between, I have the brachialis muscle, that is number 2. And here I have the pronator teres, right? So 3. So 3 muscles from the lateral to the medial side, we have brachioradialis. In between, we have brachialis, and then we have the pronator teres. Now, when it goes to this 2, what is this 2? 2 is 2 nerves you will be seeing on the anterior aspect, right? 1 is the median nerve. So this median nerve will be present between brachialis and the pronator teres, right? And your radial nerve, this is the radial nerve, where it will be present between the brachialis and the brachioradialis, fine? Then there is one tendon, because the biceps, what you have seen, the long and the short head, they combine to form a tendon, right? So it has got two tendons. One is the proximal one and then is the distal one. So proximal, you have two. One is the short head and the long head. Then they combine to form the muscle belly. Then again, a tendon, right? Where these two heads will be getting, I should say, they will be intermingling with each other, and then they will be getting attached to the radial tuberosity. So here it is not a muscle, it is a tendon, right? So there is one tendon. Which tendon? Distal biceps tendon. And there'll be one artery. Which artery? It is the brachial artery. So if somebody will ask you what exactly are the structures which are present on the anterior elbow, so your answer should be, you just say to yourself within yourself, you just keep on repeating. It is 3-2-1-1 rule. 3 is for 3 muscles from the lateral to the medial side. It is the brachioradialis, then the brachialis, and then your pronator teres. 2 is for 2 nerves. So brachialis is in the center, right? So one nerve is in between the brachioradialis and the brachialis. So that is your radial nerve. Another nerve which is present in between the brachialis and the pronator teres. So that is your median nerve. There is one tendon, that is the distal biceps tendon, and there is one artery, that is the brachial artery. So where this brachialis muscle will attach, take its origin from the anterior surface of the shaft of the humerus, and it attaches itself to the ulnar tuberosity. Now, when it comes to the long head of when it comes to the distal biceps tendon, right? So this distal biceps tendon, it sends out some of its fibers, right, towards the medial side. And this will be intermingling with the flexor pronator complex. And this we call it as Lesartus fibrosus or bicipital aponeurosis, right? And then this long head of the biceps, it just inserts itself on the radial tuberosity. Fine. And it has got an oblique course, and that's the reason it is very difficult to identify it with the anterior approach. We have 2 more approaches to identify it very nicely, which I'll be showing you today. So one is the lateral approach, where we will be seeing it from the lateral side, right? So I'll be just explaining you this. Just remember it. And I should say, this is the article which I'll be sharing, so you can go back and you can read. The silent feature of this article is, with this approach, you will be able to see the long head of the, again, I'm saying long head, I'm really sorry. I just took a shoulder class, so it is there in my head. Okay, so it is the distal biceps tendon, right? And in this, I should say, this approach, you will not be able to see the insertion of it very nicely, because you have the supinator muscle, which will be on the top. And this supinator muscle will be casting in, refractile shadowing. So you will not be able to see the insertion nicely, but it is also a very good method to identify whether, there is any kind of break in the fibers, whether there is any kind of a partial tear, or whether there is any kind of a full thickness tear of the distal biceps tendon. Another, this is the cobra position. This position is the one which everybody should know, because this is the one which we pain physicians will be using in order to go for any intervention of the distal biceps tendon. Do remember, the name of this position is cobra, which I will be again describing, right? Then comes the median nerve. So median nerve, once it enters the elbow joint, it has got its companion, that is a brachial artery. So first step, because now you're just learning the MSK, so you should know what exactly are the parts where, this median nerve can get entrapped. This is much more important for us, right? So this median nerve, initially it passes beneath this Lesartus fibrosus. So it passes beneath this Lesartus fibrosus. Later on, it enters between the 2 heads of the pronator teres. It passes between the 2 heads of the pronator teres, and then it enters into this arcade of your flexor digitorum superficialis, which has got 2 heads. One is from this anterior border of the radius, and the other one as a trochleohumeral head from the medial aspect of the coronoid process, and the as a part of your common flexor tendon. So now these 2 heads, they combine. So that is the aponeurotic portion of it. If it becomes fibrous, then also it's a site for the entrapment of the median nerve. So median nerve, once it enters the elbow, it passes beneath the Lesartus fibrosus. Then it passes between the 2 heads of the pronator teres, and then it passes, I should say, below the two heads of your flexor digitorum superficialis, and then it lies in an oblique, then it lies in a facial plane between your FDS and FDP. So I'll be showing you today till then. Then comes your medial side. So medial side, you have the medial collateral ligament. We do call it as ulnar collateral ligament. It has got three bands: anterior band, posterior band, and a transverse band. So this anterior band will be lying just beneath the common flexor tendon. And this is the most important, I should say, the part of your ulnar collateral ligament, because this is the one which will be not letting this elbow go into the valgus right position. So this is the one which is really helping the elbow a lot. And then is the posterior band, which we can, some portion of it, which we will be able to see when we'll be looking at the cubital tunnel. But this transverse, you cannot see it with ultrasound, right? So this is the three parts of the ulnar collateral ligament, which is present on the medial side. Then on the top of it, you're going to have your common flexor tendon, means there is a tendinous portion through which all the muscles will be taking its origin. And this is present on the medial epicondyle. Then what are the muscles? So you have pronator teres, you have flexor carpi radialis, palmaris longus, flexor carpi ulnaris, humeral head, because it does have a ulnar head, which I'll be showing you, which take its origin from the, I should say, the medial side of your olecranon process. So these four muscles, and beneath that, you're going to have your flexor digitorum superficialis. So these five muscles, they take its origin from the tendinous portion, which is there on the medial epicondyle. And this we call it as common flexor tendon, right? Again, on the medial side, what all you will be seeing? You will be seeing the three parts of the ulnar collateral ligament. Anterior band from the medial epicondyle, it goes up to the sublime tubercle of the ulna, right? Then the posterior band, again from the medial epicondyle, it goes to the olecranon process, and then the transverse band, which will be connecting these two. Then you have the common flexor tendon, which is basically, I should say, tendinous origin of the five muscles, right? So you have pronator teres, flexor carpi radialis, palmaris longus, flexor carpi ulnaris, and beneath that, you're going to have your flexor digitorum superficialis, okay? Then is the cubital tunnel. So this cubital tunnel is basically an osteofibrous tunnel, which is present on the posterior medial aspect of the elbow joint. Though it is there in the posterior, but since it was there in the medial, so I thought I'll just cover it up. So this, on one side here, you have the medial epicondyle. On one side is the olecranon process, right? So what is there? There'll be, if you see, this is one bone, this is one bone, and there should be something which will be forming the floor of it. So floor is formed by the capsule of the elbow joint and the posterior band of the ulnar collateral ligament. Now, when you see the roof is formed by Osborn's ligament, okay? And through it, the ulnar nerve passes by, right? Because now it has become a closed space. You have a roof, that is the Osborn's ligament. Then some people do not call it as Osborn's ligament. They call it as cubital retinaculum. So whatever you feel like, you can call it. We do have these two terminologies. I prefer to call it as Osborn's ligament. So this is one which will be connecting the two bones, right? So here you have the olecranon process. Here you have the medial epicondyle. So that becomes the roof. Now you have a floor. So this floor is by the capsule and the posterior band of the ulnar collateral ligament. So fully it is an osteofibrous tunnel now through which the ulnar nerve it passes. Later on, this ulnar nerve it passes between the two heads of your flexor carpi ulnaris. So we have already seen the humeral head. Humeral head will be from the tendinous portion of the common flexor tendon, and then you have an ulnar head which is on the medial side of your olecranon process. Now these two, they combine, right? And then they form the muscle belly. And they say that this Osborn's ligament only is spreading, and this will be covering these two heads together, right? So they say this cubital retinaculum, again, they say that it is nothing but it is an extension of the fibers from the Osborn's ligament. And that is the reason some people, they call it as Osborn's ligament. Some people, they call it as cubital retinaculum. So I think, okay. what I thought actually, that since there are two nerves today, median and the ulnar and radial. Radial will be covered when they will be taking the lateral and the posterior side. I thought that I will cover the ulnar today nicely till the hands, what all tests and all are there, which I'll be describing in the pathology section. Median, I will just cover only till forearm, right? And the rest, when I'll be taking the carpal tunnel syndrome, I will talk about the hand innervation and all during that time. So for today's, you should learn what exactly are the muscles which the ulnar nerve will innervate. This is very, very important for you, right? Because all the test, if you know what all muscles it supplies, then learning the test has become very easy, right? So ulnar nerve, once it has come out of the, the cubital tunnel, it then runs beneath, in between, I should say, the flexor digitorum, right? And the flexor carpi ulnaris, right? So if it is running in between these two, means it should be supplying these two muscles. So it will be giving a tweak to your flexor carpi ulnaris and the medial side of your flexor digitorum profundus. Okay, because it is running in between these two muscles. So obviously it will be supplying these two. But flexor digitorum profundus, only the medial side, right? Not the lateral side, because lateral is supplied by your anterior interosseous nerve. Then when it comes to the hand muscles, so remember that this ulnar nerve, because it is on the ulnar side, right? So it will be supplying this is your thenar eminence, and this is your hypothenar. So all the muscles of the hypothenar will be supplied by the ulnar nerve. Now, along with that, the ulnar nerve will also be supplying the deep head of your flexor pollicis brevis. Okay, it has got two heads, superficial and deep. So deep head will be supplied by ulnar nerve and superficial will be supplied by your median nerve, right? So that is a dual supply muscle. Then there is something which is very important, that is adductor pollicis. Okay, adductor means which is bringing this thumb close to the palm. That is the adductor. This is the function of the adductor pollicis. So this is supplied by ulnar nerve. Though it is present on the I should say the median nerve side, but this muscle is supplied by your ulnar nerve. Then it supplies the dorsal interosseous, the palmar interosseous, and it does supply the medial side of the two lumbricals. Okay, this much you need to remember. That again, I'm repeating because this is something which you need to test if you are really expecting it to be a patient of cubital tunnel syndrome. So the first thing, it supplies what all muscle? It supplies FCU and the medial half of your flexor digitorum profundus, right? So you remember this picture and you will not forget it. Then it comes to the lumbricals, right? And then the dorsal and the palmar interosseous and the muscles which are present on the hypothenar side, except two muscles which are present on the thenar side, which are not supplied by median nerve. So they are the deep head of your flexor pollicis and brevis and the adductor pollicis. Right, this much you should remember when it comes to ulnar nerve, because what all tests today I will be describing, if you know this, then it becomes very easy for you to remember it. So this much in the anatomy. Now, if you have any doubt, you can quickly ask me, or we will be revising the anatomy again when I'll be just demonstrating. So if you have any doubts, you can ask me in the anatomy. No doubts? Everything is clear? So you will be answering when I'll be scanning. So usually when you scan, always remember the position, how exactly you are gonna scan the patient. Most of the time, elbow, I scan in a sitting posture, but today I'm scanning in the, when my volunteer is in a lying down position. But you can scan it in the sitting posture as well. Fine. So whenever you start scanning, the first and the foremost thing is what exactly should be the position, right? So you should be comfortable, right? Patient should be comfortable, or your volunteer should be comfortable. Your ergonomics should be very much proper, right? So I am sitting here, machine is exactly in front of me. So my ergonomics are proper, though I have a laptop on my left side, but my ergonomics with the machine is exactly in line. So I need not strain my neck so much when I'm scanning, right? Now, this volunteer is lying down in the supine posture for his, comfort. I have kept a pillow here so that, when I'm scanning him for a longer time, it doesn't hurt him, right? Keeping it on the hand rest, sometimes it causes pain. So I don't want to give him that much amount of pain. So I have just kept a pillow here, right, beneath whole of the upper limb. Now, what you are supposed to do is, if you want to scan it, what exactly is the position of this volunteer is, his shoulder is abducted 90 degree, elbow is extended, forearm is supinated and palm facing up. So when you want to scan the anterior elbow, this should be the position, right? Whether he is in the lying down position, then it will be the shoulder abduction, right? If he is in the sitting posture, then it will be the shoulder flexion, right? But when it comes to elbow, it should be extended, forearm should be supinated, and palm facing up. So these three things you should remember and you should not forget when you are scanning, okay? So my screen is visible to all of you?
Yes,
Everyone? Okay. So now position is confirmed, right? So the second thing always will be the probe. What probe you will use? Because there is no, what to say, the hard or fast rule. Okay. I'll tell you why I'm telling you. Go back to the basic class which I have taken. When you want to examine something which is very superficial at a depth of 4 centimeter, you are going to go for a linear probe, right? So linear probe, you can have a broad bandwidth, like mine is L4 to 20, means I can just operate between these three frequencies, with frequency from 4 megahertz to 20 megahertz, right? And I'm using this probe. Now, supposedly you have 3 to 13, you can go for that also. And many times, like suppose you are examining a very fat, like a patient who is too obese, even the fat layer itself is of 4 centimeter. Even if you have to examine the elbow, you can just use the curvilinear probe. So there is no hard and fast rule. It is depending on the body habitus of the individual. But in most of the cases, like for a shoulder, elbow, wrist, ankle, knee, we go for a linear probe. And when we want to examine the hip and the spine, we go for a curvilinear probe, right? So that is the probe. First is always the position. Second is the probe which you are using. So I'm going to use a linear probe. And then the frequency, yes, I'm going to use a frequency of 20 megahertz, right? Now, few things which you should know. Now, if you will flex like this, right? So there is one line which is coming. So that is your elbow crease. Now, this elbow crease will be corresponding to the distal articulating end of the humerus. So now go back to the anatomy which I have taught you. The distal articulating end of the humerus will be having a rounded capitulum and a V-shaped trochlea. Means if I am gonna examine, if this is my humerus, which is coming like this, so this will be the distal articulating end of the humerus. And if I am going to put my probe in short axis with the aspic marker towards the lateral side means towards the thumb side, right? This is thumb, this is little finger. So if I am going to keep my probe in that manner, exactly over the elbow crease, I should be looking for what exactly we have learned in the anatomy. Supposedly, you are not keeping it, you are not finding it. Just remember that line which I am going to teach you. So you can either start below the elbow crease, you can go to that point, or you can start from above and you can come to this point. So where you have to stop where you will be able to see the capitulum and the trochlea together. Is this point clear to everyone? Because this is very important. The first step when you examine the elbow. Okay, I have a question in the chat. Okay, Dr. Nicholas, I think your query is solved. What you asked me?
Thank you, ma'am. We've answered already. I asked
Okay.
earlier.
Okay.
You've answered. Thank
So
you.
now, if this is the humerus, if This is my linear probe, right? If I'm keeping my probe, if this is my elbow crease, right? So if I'm keeping my probe here, so I should see something like this. Okay, let me increase the gain. Just a second. Okay. So you should stop when you are able to see something like this. I will go into the convex mode so that you know what exactly I'm trying to tell you. So this is the thing which we have seen. Okay, I will mark it for you so that you know what exactly we are looking for. Let me change the setting if it becomes better. Okay, this is better. So first we will learn the bony thing and then I will go to the muscle and the nerves. So we learn that if we are gonna stop at the distal articulating end of the humerus, we should see something which is a rounded one. Okay, my annotations are not on. So we should stop where we should be able to see something like this. Okay, so this is rounded one, and this is something like this, right? So rounded one was, who can tell me what was the rounded one we learned? Anybody?
Capital. Capitulum.
Capitulum. Very good. And what was that V-shaped thing which we have seen?
Trochlea.
Trochlea. Right? And this must be the groove between these two. Right? Now, what you need to remember here is, so if I will see it just like an undulating line. So you should keep your probe and you should try to find something like this. Okay, a curvy, as if one wave is going on the, you know, when you are just sitting at the beach, one wave is coming. Something like that you need to find out, right? So this is the point. This is your home page. I always say that if in ultrasound, every joint I have my own home page. So this is the home page for me. If I'm lost somewhere, I'll come back to this page and again I will see. So this is our home page where you are able to see the capitulum and the trochlea. So these bony things, once it is clear to you, then you are able to see something like this, the black one, homogeneously hypoechoic. So what we have learned in our basic class, hyaline cartilage is the one which is present, right, at the synovial articulation. And hyaline cartilage, you remember what I taught you, homogeneously hypoechoic. So 3H, which we learned during our basic class. Hyaline cartilage, homogeneously hypoechoic. So that is the hyaline cartilage which you are looking at. Now, over it, if you will see, then there is something, one white thing which you are seeing. So that must be the capsule. So that is the capsule of the elbow joint. Got it? So you should know the capitulum, you should know the trochlea, you should know the hyaline cartilage, you should know the capsule. So this much was the bony thing which you should know when you are looking at the anterior elbow. Now, two more things which we learn, right? What all we learn? We learn the fossas. Fine. So what exactly the fossas we will see? So that I will show you now. So for that, what we are supposed to do, if this is your elbow joint, this is the medial epicondyle, right? The bony thing which is present on the medial side, the bumpy thing, which I'm able to palpate also. You can also do it on your own body and you can find out. So that is the medial epicondyle, approximately 2 fingers from there. If you will keep your probe in a craniocaudal direction, we will be now looking at the sagittal section, right? Now we looked at the axial section. And now I'll be looking at the sagittal section because my probe will be in the craniocaudal direction. So what I'm going to do, if this is my medial epicondyle, approximately 2 fingers, so that, you know, because you are learning ultrasound for the first time. So you should know where exactly you are supposed to keep the probe so that you see the structure. You know, the moment you will keep the probe, you will see the structure, right? So now we'll keep our probe here. And once you will keep your probe there, first I will show you the fossa and then we'll see the other bony things. Now, what did we learn? Go back again to the anatomy. What did I say you? If you know the bone, ultrasound is super duper easy. So what did we learn? We learned that we had something, the shaft was coming like this, and then the shaft was having a depression. So if you can imagine, it is just like the ice cream scoop, right? And this was harboring some fat pad. And these fat pads, they are extra synovial and intracapsular. Do remember this one simple line. It is going to give you lots of meaning when it comes to effusion, right? Now, these fat pads, now go back to that anatomy and correlate it with what exactly we are seeing. So that is the shaft which was coming. Now this shaft is having something like a concave, something here like this, okay? And this is having something like this. So what it means that was the shaft. This is the concave depression which you are seeing. And this concave depression is harboring the fat pads. And on the top of fat pads, because they are extra synovial and intracapsular, so it should be the capsule which is going. Fine. So you are able to see one thing here, right? And something here. So this line is the, because it is on the medial side, right? I have not moved my probe on the lateral side. So this should be the coronoid fossa harboring the fat pad. Okay. So if this much is clear, then you move your probe down. And once you will move your probe down, so now, once you will move your probe down from there, you will see something like this. Okay. So what did we learn? We learned that the one was the fossa, and this fossa beneath that you will be able to see the trochlea. Okay. Now see, this trochlea is having the cartilage. This black which you are seeing, that is the cartilage, and on the top you are going to have the capsule. Okay. So you have the depression, then you have the trochlea. Trochlea is covered with hyaline cartilage, and that's why you're looking something like this. And then on the top, you're going to have the capsule. So once you have seen that, so I'll just go back again here. Okay. So this was the one which we have seen. Now from there, I have just slided my probe down, maintaining the same orientation, craniocaudal orientation. So this is the cranial side and this is the caudal side. Now this is the complete picture. Okay. So this was that depression. This is that fat pad. That is your trochlea. Now this pointed thing, who can tell me? I taught you vertex in 2 line segments. What was that? A part of ulna? Anybody?
Coronoid process.
Yes, very good. So this is your coronoid process, because this was the coronoid fossa. So this will be going inside this during the elbow flexion, right? So that is your coronoid process. And then again, you are seeing this is the capsule. Fine. I hope this much is clear. This is brachialis muscle. All this we will come in a while. But right now, learn the bony thing, which is very important first, right? And then we'll go to the muscle and the nerves. So that is over. Now, maintaining the same orientation means my probe will be in the craniocaudal direction. The craniocaudal means the aspect marker is now towards the patient. Okay. So this was the medial epicondyle, 2 fingers. Then I have kept my probe. Then what I'm going to do, my probe was here, right? Our probe was here. We were looking at this structure. So maintaining the same orientation, you slide your probe and you will see that something will change here. Okay. When you move it, convex was better, wider vision. Was trying to get more of bone. So now again here, bony thing. This will be the radial fossa harboring the fat pad. This one is your capitulum. And you see this one is like this. So that is your radial head. This is your radiocapitular joint. And what you are seeing here, that is the capsule which is going, and then it is intermingling with the annular ligament which is present on the head of the radius, which will be described in the next class, right? So this are very important. So this is anterior medial recess, anterior lateral recess, right? So one on this side, one on this side. These two you need to remember, and very easy. First, you have seen it like this. You have identified all the bones, and then you have rotated your probe in the longitudinal axis, and you have looked for the sagittal section. You have looked for the trochleoulnar joint. You have looked for the radiocapitular joint. You have looked at the fossas. So that is how the screening should be going on when you are examining the elbow. Now, the most important thing which you need to remember here is these fat pads, they should be lying closer to this bone. If they are not lying closer, then what is happening, which we will see in our subsequent slides. Okay, so I hope this much is clear to everyone. Now we'll learn the muscles. So again, we'll go back. So now this much we have learned. Now we'll learn the muscle. So what was the muscle, which was the lateral most? Who can tell me what muscle you are seeing right now? Remember 3-2-1-1 rule? This muscle? Brachioradialis. Very good. Okay. Now, if I am moving my probe, what should be the muscle which should be there in the center? Anybody?
Brachialis.
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 This is brachialis.
Brachialis.
Now, here I would like to tell you one thing. I just freeze it, I think, little before. I'll show you again, don't worry. So now, this is your brachialis, okay? Now, something which is going here from the brachialis itself, that is a tendon of the brachialis, okay? So I'm showing you again. See, if I am here, this is the oblique facial plane. Okay, let me clear the drawing. So this is the oblique facial plane where you are able to see two dots, right? So what these two dots are? Radial side between the brachialis and the brachioradialis, what you will see?
Radial nerve.
Radial nerve. Okay. So that is the radial nerve which you are seeing. So that is the oblique facial plane where you are this white, what you are seeing, that is the oblique facial plane. Now, if I am moving towards this side, again, there is some white thing which I am seeing. So that is the myotendinous junction of the brachialis, which this brachialis has started to form. So do not think and do not try to look for, the nerves if you see some white line here, right? It should always be in a facial plane, and it should always be between this brachialis and the brachioradialis, and this is the brachialis. So if you will see, I'll tell you that you remember it like this, a pyramid. Okay. So pyramid, this portion will be having the radial nerve, and this portion will be having the median nerve. Okay. So brachialis is in the center, and on one side, this is your radial nerve. Okay. And if you go to the other side, that is your median nerve. And what muscle you are seeing here, that is the pronator teres. Okay. And what white you are seeing here, that is the tendon which has started forming within the brachialis. So do not try to look for the nerve here. You should be looking for the nerve on this side, right? So again, we'll go back to a rule. This was brachioradialis. Again, a repetition of what we have learned. Then muscle. This is the brachialis, what we are seeing here in the center. If I go to this side, that is the pronator, which I am seeing. Okay, so 3 muscle is over. Then comes 2. What was the 2? One is this. This is the radial nerve. Now this radial nerve, where it is present between the brachialis and the brachioradialis in an oblique facial plane. right? Now, if I will go to this side, what I should see? I should see the median nerve, which is lying in an oblique facial plane between brachialis and the pronator teres. So 2 is also over. Now, what is left? Left is the artery. Where is the artery? This is the artery. Okay. And 1 is the tendon. Where is the tendon? So if I will here, I will show you something else also. Okay. So this is the tendon. Now there is something here. If all your anesthesia people can tell me, then I will give you 100 marks today. 100 on 100. Who can tell me what is there?
Bicep tendon.
That is bicep tendon is there, but one honeycomb-like structure. Okay, I will show you again. Are you able to see one honeycomb here?
Madam, screen is not visible properly, madam.
Huh?
The ultrasound screen is not visible. Half of the screen is only visible.
It's not visible. Chinmoyda?
It's visible, madam.
Madam, screen
Upper side.
is visible,
Only
but only half of the screen is visible.
Half of
Yeah, because I have reduced the depth.
Okay,
That's why.
madam. Okay.
Yes, no.
Yeah, I wanted to show you something which is very superficial. So I have reduced the depth to 1 centimeter. Otherwise, we will not be able to see the structure. Okay, this is lateral cutaneous nerve of the forearm. Okay, the one which you are seeing here. Okay, and this is your biceps tendon. Got it? Never miss this nerve, and it is lying very close to your cephalic vein. Now I will increase the depth.
Madam, which branch, madam? The lateral cutaneous nerve forearm.
Lateral cutaneous nerve of the forearm is your musculocutaneous nerve. It will come and then it will come in the subcutaneous plane. I'll show you the musculocutaneous also, but I'm just showing you here because we are just looking at all the structures here. Okay. So this one, see the small one which you are seeing. Never forget this, because if you are doing an intervention to the cephalic vein, it lies very close to it. Because if I'm going to come down, this will be going into the subcutaneous plane. See, it has gone.
Okay.
Okay. So that's why I showed you here itself, that whenever you are looking the anterior elbow, you try to look for the biceps tendon. This is the biceps tendon. Next to that, you will be having the lateral cutaneous nerve of the forearm. Okay. And this will be your cephalic vein. So this much finishes the anterior elbow, all the structures. Right now, one by one, we'll see them in detail. Okay. So first of all, we'll see the biceps. So we learned that the biceps, this is again, I'm back to the home page. Okay. So this is our home page, which we were seeing. Okay. And this is your biceps tendon. Are you able to see the tendon nicely? This is your tendon. Everyone is able to see the tendon? Now, once you are able to see the tendon, we need to see the Lisartus fibrosis, right? So our probe is in, when home page, I'm not repeating the probe position because home page means probe is in short axis to the distal end of the humerus. Aspect marker is towards the lateral side. That was the reason of labeling it home page. So we did not repeat the, the position again and again. Now, you just slide your probe medially. So once you have slided, you will be able to see the brachial artery and the median nerve lying adjacent to it. Now, in order to see it nicely, you tilt the medial side of it. You start tilting, you keep one side fixed, and then you tilt the other side. Are you able to see it nicely now? So this should be the position. And now we will see that, because this is important when you are seeing. So this was your biceps tendon. Now you see, this is the one which is going and intermingling with the flexor pronator complex. Okay. You have your median nerve, which is here. You have your brachial artery, which is here. right? So what you are supposed to do from the home page, if this is the home page, right? Home page means this aspect marker is lateral side, it's towards the lateral side. To try to tilt it slightly, the medial portion. Keep this portion fixed and try to tilt it. You will exactly get this picture, right? So once you are getting this picture, you are supposed to look for the Lesatus fibrosis, right? That there is no break in it. It is not thickened. This we will be covering in the subsequent slide. So that time you can see. So that is one thing which you need to see. Now from there, if I'm going to go up, so if this was the biceps tendon, you keep on going up. So you will see that this is the nerve. Now it has started coming here. Now it will go in between the brachialis and the biceps. Okay. Now to easy way to identify it is, this was the tendinous portion of the biceps muscle, which we were seeing. Now you will see that this will start, breaking it into muscle, right? This is what I'm trying to show you. Fine. Okay, let me freeze it here. So from our home page position, maintaining the same probe orientation, if you're going to go up, you will be seeing this is the central aponeurosis, okay, of your biceps. Now this is one head, short and the long head. And this one which you are seeing here, this is your musculocutaneous nerve and this is your brachialis muscle. Okay, and this is your biceps. Fine. So from there you can go up to the, I think above that Dr. Chinmay would have taught you how to look for the myotendinous junction. So you keep on coming down, you try to evaluate the whole portion of it, right? So you will end up here where I have just stopped, right? So you see both the heads, you see the aponeurosis nicely, and this is the musculocutaneous nerve, right? And this is your brachialis muscle. So this is how you look for them, by just moving your probe from the home page position to the proximal one. Now, once you have identified that, if you want to look biceps, we do not, brachialis, we do not have so much of pathology to look for, right? But still, if you want to look for its insertion, you can see it. So go back to the home page position. So this is the home page, right? This is the brachialis muscle, which you are seeing now. Now, if you are seeing the brachialis muscle, you just keep it over the brachialis. So that is the brachialis, which I'm seeing. Now you rotate your probe. Once you have rotated your probe, you will start seeing the brachialis in the long axis, right? Now you slide your probe, how it is going. I freeze it here. So we saw the brachialis in the short axis, then we rotated the probe, right? This is the coronoid process. So if I'll go down, the coronoid process somewhere here will be the ulnar tuberosity. This is coming like this, okay? Now one hyperechoic thing which you are seeing, that is the tendinous portion of the tendon which is inside this muscle itself. So this is your brachialis muscle which is getting inserted on the ulnar tuberosity. Now, once you are seeing this brachialis muscle, if I will go towards the medial side, you will be seeing the median nerve, right? And if I tilt my probe towards the, I should say the lateral side, I will be able to see some portion of the distal biceps tendon getting inserted on the radial tuberosity. Many of the patients, it is nicely seen. Some of the patients, I should say most of the patient, anterior approach is very difficult. But I will just try to show it if it is possible. So again, we go back to brachialis. So our probe is in short axis, aspect marker towards the lateral side, and we are seeing the brachialis muscle. This is the brachialis, which, oh, sorry, let me remove. So this is the brachialis, which is there in the center. Okay. So now I have rotated my probe. Once I have rotated my probe, I will be able to see the brachialis. Now this brachialis is coming down coming down. I'll just tilt the footprint towards the medial side so that I can just see the ulnar nicely, ulnar tuberosity, but still I can just see this much. I'll just try to toggle my probe just to see, but I think it has got a curve, this thing. So this, I'm not able to see it nicely. So once you have seen that, now you just go towards the medial side. Once you are going towards the medial side, maintaining the probe in the same orientation, now you will be seeing something like this. Okay. What is that? That is the brachial artery, okay, which you are seeing. So from the brachial artery, I should be able to see the nerve, okay. So what you are seeing here now is the nerve. I have compressed it so much so that you are not able to see, but still some pulsations of that is there. So now what we are seeing is the median nerve, right? You can use this technique, or you can just start it in the short axis, rotate your probe in the long axis. That also I will be showing you. So that is the median nerve, right? This is your brachialis. This is your brachialis muscle, and that is your pronator teres. Both the muscles you are seeing in the longitudinal axis, right? Now from there, if I am coming down, okay, and I'm just, I should say, toggling my probe so that I'm able to see things nicely. Okay, so I will just freeze it here. So first, we have learned that the median nerve is in between the brachialis and the pronator teres. Then the median nerve passes between the two heads of the pronator teres, and then it enters the aponeurosis of your FDS. Okay. Now here I would like to give you a tip. Okay. The tip is, this is your nerve which is coming. Okay. Do not think that this is your nerve. This is the myotendinous junction of your pronator teres muscle. Okay. Now the pronator teres muscle, superficial head is very big. Okay. But the deep head is very, very small. You can see it here. It is very, very small. And if you are confused whether you are looking at the deep head or not, then it will be the ulnar artery, which will be lying deeper to the deep head of your pronator teres, right? So this nerve you try to follow. I have, I usually follow it in the longitudinal axis, because if there is any kind of entrapment, then the nerve, what exactly is the basics, of nerve entrapment pathologies is you have a proximal dilatation of the nerve. So, but if your nerve is running very smoothly like this, then there is nothing, no entrapment. But if there is an entrapment, your nerve will be something like this, and then it will be pissed off like this. So this dilatation will be helping you to identify that, okay, at this side, because just before the entrapment, if this is the entrapment side, just before the entrapment, there'll be a proximal dilatation of the nerve, right? So this will really be helping you to see that, okay, now this structure is the one which is pathological. So try to follow the nerve in the longitudinal axis. It really helps to you a lot, right? So this is the nerve which we will be following. Let me change if I can use this. Just 1 second. So we are just going to follow it again. Okay. So we were trying to look for the brachialis, right? So the brachialis, this is the It's still dark. I have increased the gain to the maximum. Okay, I think it is visible now. I've increased the gain to maximum so that you can get a good picture. So again, my probe is in the craniocaudal direction. I'm looking at the longitudinal axis of the brachialis muscle. And this is the trochleo ulnar joint. Okay, the rounded trochlea and the pointed coronoid process. Now, if I'll slide down, so that was the brachialis muscle. And if I'll tilt my probe to footprint towards the medial side, or if I keep on tilting, where exactly I'm able to see the arterial pulsation. So that is the arterial pulsation. Okay. Then you keep on sliding your probe and you try to look for the nerve, right? So this one which you are seeing here, that is the nerve which is going. Okay. So we will see it again. Okay. So now you see. So here you need to use all your maneuvers to see it nicely, right? So this is your pronator, that is your nerve, and beneath that is your artery, and this is your brachialis muscle. This is artery, this is nerve, this is pronator teres muscle. Fine. You keep on coming down. Okay. Again, that is the artery. Nicely seen. This is the nerve, which we are able to see. So this is the nerve. Now, if I will come down, see, don't consider it nerve. Again, I'm telling you, this is the myotendinous junction of the pronator teres. Okay. So nerve is this one, which is just lying above here. So you keep on following it, And if I will just toggle my probe a bit, I can show you. So this head is the deep head. It is very small. Do not expect it to be a bigger one, and you will be able to see a very big head. That is an anatomical then variation. Either it is absent or if it is very big, right? Usually it is a very small one. And then you keep on following this now. Once you are following, again, you toggle your probe. I'm just toggling my probe just to get a better picture of this nerve. Now, once it has come here, you will see that it has entered into the, this is your FDS. It is entering now into the FDS. And if I'll slide my probe more, so now it has entered into FDS. So you need to follow, you need to keep on toggling, right? See what I'm doing, very slight motions of my hand, okay? And I'm just trying to look for this now. We'll go up. See, you just toggle your probe little on this side, that side. Means you just try to toggle it towards the medial side, towards the lateral side, so that you are able to see the nerve nicely, right? So this is how you follow the median nerve. You keep on following it like this, keep on toggling, and then keep on toggling, and then you will see that you have reached there, right? Between the brachialis and the pronator teres, that was our home page, right? So you can follow it like that. Then once you have seen the brachialis, okay, again, we'll go back to our brachialis where we were seeing the brachialis. So that was a brachialis insertion which we were seeing. And one way we identified the median nerve in the longitudinal axis. Now from there, if I will tilt my probe towards the radial head, like this. So the footprint is tilted towards the lateral side. If I'm able to do that, once I'm doing this, what you are seeing here, that is the artery, and beneath that will be the biceps. This is the radial head, this is the neck, and this is the tuberosity. Though it is difficult to look at this aspect, but at least you will get a rough idea if there is any kind of, you have a tear here. So you will not be able to see this. There'll be black halos again, which we will be showing. I'll be showing you in the pathology slides. So at least you will get an idea that, okay, there is no problem with the distal tendon of the biceps, right? Now, this is the easiest way to just have a brief idea about the nerve, about the brachialis and the distal biceps tendon, right? Whether everything, three things on the, I should say, the medial side is perfect or not. I follow this technique and I find, everything you can see it in a go. Now, if distal biceps tendon, you are not able to see it, then what exactly you can do? So then comes your lateral approach. So lateral, dorsal, that is, you need to flex the elbow. Okay. So now you keep your hand, the elbow is flexed, forearm is pronated. So this is the position you need to keep. Now, with the aspect marker towards the thumb of the patient, if this is your lateral epicondyle, right? So this must be, if you keep on going, you will see one dip here. So that dip will be your radiocapitular joint. And after that, obviously, it's going to be the radial head. So you try to keep it there, right? So once you will keep it there and slide your probe anteriorly. That's all. Where you have found that dip, you keep it there and then you just, I have palpated, I have kept my probe exactly over it, right? So I'm in the short axis to the radius. Now, if I will go up, means if I'll slide my probe towards the thumb, you will be able to see a fibrillar structure. So that is the radius. Okay. This is your supinator muscle. And something which you are able to see here, that is your distal biceps tendon. And you can see the arterial pulsation also. Okay. So always try to find it next to the artery, because the arrangement was you had a biceps tendon. Here you had the brachial artery and here you had the nerve. So this is biceps tendon, brachial artery, and then the median nerve. So it is BAN. You can remember it like that. So biceps tendon will be lying in close approximation to the artery, right? Now, again, if you are not sure whether you are looking at the biceps tendon or not, so what you can do is you keep it there and fix it with one hand and then try to move. You will see that this is also moving. Okay. Right. So that is how you can confirm. Now comes the cobra position, which is for us where we have to give the intervention. So this is, you need to flex the elbow and fully pronate it. Okay. And then your wrist into flexion. It's just like you have to make a snake like this. Okay. Wrist flexed, elbow flexed, forearm hyperpronated. Now you palpate the olecranon process. This is the olecranon process. Okay, so this should be the portion of the ulna, right? So you look for the subcutaneous ulna and approximately 2 fingers from there, you keep your probe in the short axis. Okay, so if you are going to keep it, you will be able to see. So you will be able to see the ulna in the short axis as a U-shaped structure. Okay. Now, once you have seen the ulna as a U-shaped structure, you try to move your probe laterally. Once you will move your probe laterally, you will see something like this. So that is your radius and that is the biceps tendon which you are seeing, which is getting inserted on the radial tuberosity. Now you're not sure. Then again, you do the pronation and the supination and you will see that it is moving. Okay. So this position is the one which we use in order to go for any kind of intervention of the long head of the biceps. Very easy to identify. Biceps with this technique. Elbow is flexed. Okay. Forearm is hyperpronated and wrist is flexed. Palpate the olecranon process. 2 fingers from the olecranon process. Put your probe in the short axis to the ulna. Look for a U-shaped structure. Okay. And then slide your probe laterally. You will see the radius, and on the top, you will be able to see something like a bird beak, and that is your distal biceps tendon. Fine. So that is the cobra position in order to visualize the biceps tendon. Now, once I think more or less I have covered brachialis, median nerve. and the distal biceps tendon technique. Now we'll go to the medial side. So medial side, you palpate the olecranon, the medial epicondyle with one hand, and then how the flexors are going. So your flexors, they are going like this. This is your pronator teres, right? Then you have your FCR, then you have your palmaris longus. This is your FCU, my little finger, and beneath that you're going to have your flexor digitorum superficialis. So if I'm going to keep my probe like this in a craniocaudal direction, I will be looking at the longitudinal axis of this muscles and then the longitudinal axis of the common flexor tendon. So what you are supposed to do here is, now, if this is the medial epicondyle, I'll reduce the depth. I think 2.5 will do. So you palpate the medial epicondyle. Again, the position is same. We have not changed anything, right? So your shoulder is in abduction, elbow extended, forearm supinated, and palm facing. So you palpate it with one finger. Then you keep your probe exactly there. So once you have kept your probe there, okay, I'll change it to elbow. Maybe the resolution will be good. Okay. So once you have kept your probe like this, okay, and you slide it up, what did we do? We palpated the medial epicondyle. We put the cranial end of our probe over it, and we just look for the medial epicondyle, right? By just toggling our probe a bit. Now, at this position, you will be able to see something like this. So this is the medial epicondyle. That is the downward slope of it. And then it becomes the trochlea. So this is the trochlea. This is the sublime tubercle of the ulna, right? Now, what you are seeing here, something like this, okay? So this is the anterior band of your ulnar collateral ligament. So if you want to look for the anterior band of the ulnar collateral ligament, so this is the position, but this is not the position to look for the common flexor tendon. Do remember that, right? So if you want to look for the anterior band of the ulnar collateral ligament, your probe is in craniocaudal direction. Aspect marker is over the medial epicondyle, and it is in line with the ulnar border, right? Now, if you want to look for the common flexor tendon, what you need to do, again, your probe was like this. Okay, so we were here, right? Now, what you need to do is you bring this medial epicondyle into your view very nicely. Now, you try tilting the caudal end of your probe. Keep on tilting until you are able to see a good tendinous amount of the tendon over the medial epicondyle. And this tendinous portion will be very nicely seen if you will orient the caudal end of your probe like this. Okay. Okay. My hand is obscuring. Okay. Show you from here like this. Okay. So this end, the caudal end of my probe is exactly toward the thenar eminence. Okay. So if you are orienting your probe, initially it was like this. Now, what did I do? I kept the cranial end fixed over the medial epicondyle, and I rotated the caudal end until it is in line with the thenar eminence of your palm, right? So now you see, you're able to see the tendinous portion nicely. So again, this is the medial epicondyle, but in this position, you are not able to see the anterior band of the ulnar collateral ligament very nicely. So this is not the position to look for the anterior band of the ulnar collateral ligament. So again, this is the downward slope, and that is the trochlea. This is the joint space. So do remember this, because recently it has come in all the previous books, even in my book, which I have written, it was like that only. But later on, when you read the articles, you upgrade yourself. So there is an upgradation of the techniques which are described in all the previous books, right? But the newer updates, they say that you need to look for the good amount of the tendinous portion, because if you'll keep it in line with that, you will be able to see the tendinous portion of your FCU alone. Right? So that is about the common flexor tendon and the anterior band of the ulnar collateral ligament. Now, coming to the cubital tunnel. So cubital tunnel, I would like to tell you one thing, that when you want to examine the cubital tunnel, okay, so the screen depth I have decreased, okay, so you might not be able to see the full screen. Never ever examine the cubital tunnel, with the elbow fully flexed. Absolutely wrong way of examining it, right? When you want to examine, and that was the reason today I thought I will examine it in the supine posture, because we need to go for the dynamic evaluation of it also. So this is 90 degree, right? This must be 45. So just keep the elbow flexed to approximately 30 degree alone. That's all, right? Do not flex it more when you are examining the cubital tunnel. Now, two things you are supposed to look for, these bony things, right? One is this bone, another one is this bone. So this bone is the medial epicondyle, and this bone is the olecranon process. So medial epicondyle, olecranon process. And where is the ulnar now? Here, right? Something like this it is coming. So you have to keep your probe bridging these two bony points. That's all. Okay. First is the position, right? Position is elbow should not be flexed more than 30 degree. Then you have to palpate these two bony things, and then you just keep your probe bridging these two. That's all. You are there in the cubital tunnel. Okay. I think it will be visible now. This is what I was telling. Just keep it and you are able to see. So this side was the medial epicondyle. This is your olecranon process. This is joint space. This is your trochlea. Now see this band which you are seeing, that is the posterior band of your ulnar collateral ligament. What you are seeing here, okay? So that is the ulnar artery. If you are able to see arterial pulsation, that is normal. You will be seeing a collateral branch there, which will be accompanying the ulnar nerve. So nothing to worry about. And what you are seeing here, something like this. So this is your Osborn's ligament, right? So this is now an osteofibrous tunnel. So this is your Osborn's ligament or retinaculum, cubital retinaculum, whatever you want to say. One bony thing, that is your olecranon process. Other one is your medial epicondyle. This one is the posterior band of the ulnar collateral ligament, and this is the ulnar nerve, right? Now, once you have identified this ulnar nerve, you trace it down. So we have looked for it here. Now I'll just trace it down. So once you are tracing it down, you will be able to see something like this. Two muscles will come, okay? One is here and one is here, right? So this is coming from the ulnar. So this is the ulnar head and this is the humeral head of your FCU, right? And this is the ulnar nerve. Some people say that this is the true cubital tunnel and that is not the cubital tunnel. So what did we do? We were here, we just slided our probe down. And if you keep on coming down, you will see that these two will combine. Okay. So see, they have combined and this hole is now your FCU. This is your flexor digitorum profundus. Okay. This is your superficialis. So do not think that these are the two heads. So if you'll go back, you will see that again, they have separated. Now, if I come down, they have combined. So this is your FCU. And if you will trace it down, okay, so you will see that it is running in between your FCU and this is your flexor digitorum profundus, okay? And later on, this will be joined by the ulnar artery. So that is the ulnar artery which has come and which has joined this ulnar. Okay, one thing more which I would like to tell you is, or I will just cover it up when I'll be just showing you the wrist. Because that time I'll be showing you the pronator quadratus. So it will be easy. I wanted to show you the anterior interosseous nerve, but we will see it there because that is important when we are talking about the wrist. Okay, anything from the demonstration? I think I have covered if anything is left. Any questions from the demonstration? Or I can just go to the pathology now. Silence means you have understood everything. So if you have understood everything, quickly I will revise and you will be answering now. Okay? So it's a quick revision for all of you. Be attentive, unmute yourself and answer. I will be asking now. Just to see what we have learned. 5 minutes revision and then we will talk about the pathology.
Excuse me.
Yes. Yes, I'm
Still I'm not that oriented about the bony contour of the elbow joint.
You are
Maybe
not.
I need
Okay, so we are
more.
revising now, na? We are revising. So you just see it again. Okay.
It will be better with the picture of the anatomy itself.
Picture of
With
the anatomy.
ultrasound.
Anatomy I have shared now. Anatomy I have taught you.
I know, but along with the ultrasound picture. So it will
Along
be
with the
more
ultrasound
oriented.
picture, you want anatomy. Right now, I cannot install another camera. Okay, so
it'll
I
be
can
more
just.
oriented.
Oh, you go back and you listen to the recordings. That's what I can say, because right now it is not possible for me to insert an anatomy, a camera which is just showing you another one. So we are just,
thank you.
okay. So I will just say, share with you again, okay, or when you are just listening to the presentation, because I have explained it very nicely. So have that picture, because I think this correlation, and if you have supposedly you are scanning, when you are listening to my presentation, you see the anatomy or the distal articulating end of the humerus is very easy. You can get a Google picture of it and you just put your probe and you just try to see what I was telling you. Exactly the same thing which I was telling you. So this is your capitulum. Okay, I have annotations whereof. So now we are revising, you go through, listen to it again so that you are able to understand. Because see, it is like, you have to, what I should say, you have to have that 3D picture in your mind. So when you're putting the probe, you are exactly seeing what we have learned in the anatomy, right? So now who can tell me what is this rounded one? Quickly, we will revise. Anyone?
Capitulum.
Yes. And this one?
Trochlea.
Okay. The white structure which is here?
Capsule.
Capsule. This
Capsule.
homogeneously hypoechoic structure?
Hyaline cartilage.
Hyaline cartilage. Okay. So something here I'm seeing, what is this?
Radial.
What is the name of this muscle?
Brachioradialis.
Brachioradialis. Okay. If I go to this side, what is this pyramid kind of a muscle which I'm seeing?
Brachialis.
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 Okay. So what is this? Something which is
Brachial
pulsating?
Brachial artery.
Artery.
Brachial artery.
One honeycomb structure next to the brachial artery.
Nerve.
Musculocutaneous.
Cutaneous nerve.
Okay. Okay. What is this?
Lateral cutaneous.
Bicep tendon.
Distal biceps tendon. Okay.
Biceps tendon.
I will release the pressure now. See, I have given you a hint. What is this?
Cephalic vein.
Cephalic vein. Okay. So if I'm coming to this side, something I'm seeing here. What is this?
Lateral cutaneous nerve.
No,
No.
it is brachial artery.
Brachial artery.
Median nerve.
It is medial nerve.
Medial nerve.
This is your brachialis muscle. And this muscle is?
Pronator teres.
Pronator teres. So between the brachialis and the pronator teres, in an oblique facial plane, we see only median nerve. Okay. Fine, this much is clear to you. Okay, now I will show you one structure. You have to tell me what structure we are seeing and in what axis we are seeing. Okay. I will not tell you what structure I'm showing you. You have to tell me. So I will mark that structure for you. This structure, who can tell me?
Brachialis.
Yes, this is brachialis muscle. Very good. See, you are able to see the tendon which is coming also from it. Okay. Now here itself, who can tell me what is this? Coronoid process. Very good. And if I go ever to the coronoid process, what am I seeing here? This one?
Trochlea.
Trochlea. So coronoid process will be articulating with the trochlea of the humerus. Okay. Now, if I go little more up, what I'm seeing, this one?
Coronoid fossa with fat pad.
Fossa is having what? Fat pad. Very good. Now, some white structure I'm seeing. I don't know what is it. Who can tell me?
Capsule.
That is the ligament.
That is the capsule. Okay, this one.
Capsule.
This is the capsule, right? And these fat pads are extrasynovial intracapsular. Fine. Okay. So I have seen the brachialis. So now I'm able to see something here. What is this?
Medial.
Brachial artery.
No, it is
Brachial
artery.
artery.
See, it is pulsating. Okay. So I will not apply much pressure. So this is artery. But if I am going more medial and I'm just toggling my probe to get a good view. Okay, this view is fine.
Median nerve.
This is your median nerve. Now, who can tell me? I have forgotten actually. So you have to tell me what is this?
Tendon.
And which is coming from pronator teres. Okay, which is forming inside the pronator teres. Okay. Fine. Okay. Okay, I have forgotten this. So let me revise this also. Okay. What is this structure?
Radial head.
Yes, radial has got a square shape pattern. See? So if this is the radial head, what this has to be?
Capitulum.
Capitulum. So capitulum is equal to radial head. You remember it like that. Coronoid process is equal to trochlea. Okay. Now if I go to the medial side, so now you have to tell me right or wrong. I have kept my probe in this manner to see the common flexor tendon. It is true or false?
False.
Okay. So what I will be seeing if my probe is exactly in line with the ulnar border?
Medial collateral ligament.
Okay. So medial collateral ligament, what I will see? Whether I will be able to see the whole of the medial collateral ligament or
No.
some portion of it.
Anterior band.
Anterior band I will be able to see. See, are you able to see that thing which we have seen?
Yes.
Okay. Fine. Okay. So, oh, I have forgotten to show you the ulnar testing also. And okay, we will see the cubital tunnel now. And then I'll show you how to look for the subluxation of the ulnar nerve. That I have forgotten to tell you. Now only I remember. Okay. So now tell me, is this the right position to look for the ulnar nerve?
No.
No.
No? Okay.
Plus minus 30-degree flexion.
Yes. So if I have kept it, now I will ask you what all structures we are seeing. So I can reduce the depth. Okay, no problem. Leave it. So what is this structure? This was the
Medial.
okay.
Medial
So
epicondyle.
sometimes if you are confused, where is your aspect marker, where you have kept it, don't get confused. Look for this line. This line is continuous, see? And it is going like this. But if you see this line, there is a break here. So olecranon process, you will have a break. This is your trochlea. This is your medial epicondyle, right? Now, who can tell me what is this structure?
Posterior bundle of ulnar. Collateral
Ulnar?
ligament.
Collateral ligament.
Yes. And something here I am able to see. This is
Ulnar nerve.
artery. This is nerve and this is your artery. Okay. Now there is something which I will be able to see. I'm seeing here going like this. What is that?
Osborne ligament.
Osborne's
Osborne
ligament or cubital retinaculum, if somebody wants to say. Okay. So now at this position, when you are keeping the probe, right? What is the gist of the story here is, let me decrease the depth a bit. Okay, 2.5 will do. Okay. No, I can reduce it further, but it will appear as cutting the screen. So, okay, let me keep it. So with this position, now you will flex the elbow. Okay. You will start flexing the elbow. And when you are flexing the elbow, you should see that the ulnar nerve should always be lying close to the medial epicondyle. If it is not lying close to the medial epicondyle, you are seeing a problematic person. Okay, this we will learn now quickly when we are learning the pathology. So first, we will keep it here. Okay, now one end you keep fixed and the other hand you start flexing. You start flexing. See, it is just lying close to the medial epicondyle. You flex, keep on flexing, flex, flex, keep on flexing. So flexed, and it is always lying closer to the medial epicondyle, right? This is your nerve and this is your medial epicondyle. It's always lying close to it. This is very important. Why? We will see. So I think we have revised everything. So now quickly we'll go through the pathology. I hope all whosoever is having any question would have got cleared when we were discussing the pathology or we were discussing the sonoanatomy. So where was we? We were here. Okay. So my slides are visible? Anyone?
Yes, yes.
Yes.
Okay. So we will learn quickly. Okay. This is quick revision now because we know the anatomy. So sonoanatomy is pathology is a quick. Now we know the anatomy and the sonoanatomy. So biceps tendon, you can have two types of things, acute tear or you can have a chronic presentation where you can have a tendinosis. So if it's an acute, it is mostly the tear, which is very much common. And the chronic conditions, you have the tendinosis, which is very much common. So always remember when you are saying tendinosis, okay, it's a long process, which is really happening inside the tendon, right? So that's why this word has come into play. Now, this acute tear, when it can happen. So it is secondary to forced extension when your elbow is in mid flexion, right? Means this is the flexion. My elbow is in mid flexion. Now, if somebody will just like that put my elbow joint into extension, I can have a tear of my distal biceps tendon. So that time I'm going to have an acute pain or you can have a pop-up like of feeling, right? This tendinosis usually is a chronic process. So you see it in the patient who are involved with weight training, okay, or whether they're just lifting, right? And here they will say that I have an anterior elbow pain. And whenever I'm just trying to lift something with the elbow, I'm having this pain is getting aggravated. This will be the presentation. So if it is a tear, okay, of your biceps tendon, we have seen it in the longitudinal axis like this. So you will be able to see only one portion of it. Rest, everything will be black to you, right? You will not be able to see anything. If you keep on tracing it up, you know, these something like this, you know, as if one retracted portion, because if this is your tendon, I'll cut it here. So what will happen? This will be getting retracted upwards, right? So this is what will happen and this is exactly what you will see. And since it's an acute rupture, so you will be seeing the hematoma around it, right? Now, so you can have a partial tear, means some you are able to see some fibers, but some fibers are missing. So that is partial. Tendinosis is always like this, big one, big hypoechoic thing you will be able to see. Now, if you want to go for an intervention, this is the cobra position. So elbow flexed, forearm hyperpronated, and your wrist is flexed, and you will be able to see this biceps tendon very nicely. Do remember, never come from the ulnar side. You cannot do an intervention because you will have a bone here, right? But if you are coming from the radial side, you can directly inject inside the tendon. So that is about the tendon, distal biceps tendon. Now the treatment, I will be just revising you along with this common flexor tendon. So common flexor tendon, initially we used to call it as golfer's elbow, but it is no longer called as golfer's elbow because you do see it in the plumber and carpenter and people who are playing other sports as well. Then they said, okay, let it call medial epicondylitis. But again, the histological studies have failed to show the inflammatory cells. And they said, no, it is not no inflammation. We could see in the, the tendinous portion of common flexor tendon. It was all degenerated things which we are seeing. So then they said, okay, let us call it as common flexor tendinopathy or epicondylgia. Both are right. So you can write it in this manner. Both terms are right, but please do not write this or this. They're all obsolete terms now. Now, what exactly happens in a tendon? So tendon, when we say, these are the parallel arrangement of the collagen fibers. So initially, when the tendon has got an insult, you will have the wavy pattern of it. Okay, the parallel fibers, they will become wavy. Now, if you keep on torturing the tendon, you are not taking care of it, then what happens? There is an angiofibroblastic hyperplasia, which will happen. Again, at this stage, you are not doing anything. You have the collagen fibers, they will break down. They'll start breaking, right? Again, if you're not taking any care, fully everything is gone. So this stage will totally be corresponding to you. Not many people will believe it, but still some researchers says that grade 1 is tenosynovitis. Grade 2 is your tendinosis stage. This is your partial tear stage, and this is your complete tear stage. Okay. So basically, if you see the histological pattern, this is how the tendon, will be having problem. Now, when it comes to the common flexor tendon, this patient, tendinopathy, this patient will be complaining of a pain, which will be around the medial epicondyle, might be radiating towards the forearm. So any kind of, the grasping activity, because here you need to have the flexion of your wrist. So that will be painful for this patient. And there is a test which we call it as reverse Cosen test. Now, what you do it in this test is you hold the elbow like how I am holding it, and then you put one of your index finger over the medial epicondyle, right? Arm by the side of the body, support the elbow, ask the patient to make a, fist, and then you put the wrist into flexion. And then you apply resistance and ask the patient to maintain the same position. If it is aggravating the patient's pain, it is positive. And we do have various, I should say variation of this Cosen test. Some people say that at the same time you stretch it. So whatever you feel like doing, you do it. But I do this. Okay, before that, I have forgotten to tell you one thing. When you are making a fist, you ask the patient to have a little bit of ulnar deviation of the wrist, right? So this is reverse Cosen test, which will be positive if it is a common flexor tendinopathy. And mostly it is diagnosis is clinical, and then you go for an ultrasound examination. Radiography doesn't have a role to play unless you are expecting it to be a fracture or a dislocation. So ultrasound, what you will see. So these are the pictures of tendinosis. So if it is a tendinosis, again, see how enlarged it is, right? You put the color Doppler, this will be taking up. When you are seeing a partial tear, how it will be? Complete absence of fibers in this. So you can have a tendinosis, you can have a partial tear of this tendon. Now, what you are supposed to do, so if it's a tendinosis, we are treating now the tendinosis, so you can go for a percutaneous needle tenotomy. Percutaneous needle tenotomy is you keep on passing your needle into the area which is having tendinosis repeatedly. So how long you can pass? Until this area will become isoechoic. Okay, isoechoic means exactly like the surrounding tendon. Or when you are passing the needle, if it is a tendinosis, you will be getting that gritty sensation. You can keep on passing until that gritty sensation goes off, right? These are the two tips where you need to stop. And what you can, how this actually helps the patient
Oh,
is,
ok.
it causes the
Je
disruption
suis
of the
dans
degeneration.
le cours, hein. Je termine peut-être d'ici là, je vais venir. On va peut-être dans 20 minutes. J'ai cours maintenant, je termine peut-être dans 15 minutes.
Are you talking to me? Somebody is speaking, I'm not able to understand.
I have muted.
Okay. So this basically causes the disruption of the degenerated process which is going on. This will be encouraging the localized bleeding, which you can see it. Okay. And then you will be having the growth factors release, and ultimately you will be having the collagen formation, right? Now, what all you can do? Some people, they do just the, needle tenotomy with a normal saline. Some take that local so that it is not painful for the patient, right? But you can just give some top-ups, like you can go for a dextrose once you have done the needle tenotomy, because dextrose, if you are using more than 10%, it causes the apoptosis of cell because of the osmosis from the cell. And then there'll be an inflammatory cascade which will be going on. And ultimately, you will have the collagen deposit, right? So added benefit of it. So dextrose you can add up to 12.5% to 15% dextrose you can take, and you can just use up to 6 to 7 ml. Some people, they have used 10 ml also, because we do not have a recommended guidelines for it. So they have used, some have used 4, some have used 5, some have used 10. So you can use according to the literature which you really feel like, right? Or you can go for a PRP also. So you can do a USG guided percutaneous needle tenotomy in a tendinosis, okay? And you can inject, means you can just give a local anesthetic, okay? No need to give anything, that is up to you. You can do a tenotomy, you can inject dextrose, or you can do a tenotomy and you can inject PRP. But when it comes to partial tear, you are not going to poke that area. Wherever you are able to see the tear portion, directly go and inject PRP or dextrose there. That's all is the treatment for this, right? And in the initial stage, obviously, you will go for a conservative management. You will give NSAIDs, you will give rest, you will give an elbow splint. I'm not covering that because that is what we usually follow in our day-to-day practice. Then comes your ligament injury. So we have seen the anterior band of the ulnar collateral ligament. So you can have an injury of it. You can have a sprain of it. Ligaments will have 3 things, okay? They have a sprain. And sprain is usually the body will heal within a period of 4 to 6 weeks. Then you can have a tear, or you can partial tear, or you can have a complete tear. So if there is a complete tear of it, then obviously the mobility of the joint will increase. Okay. So complete tear, do not try to do anything. You can just send it directly to your orthopedic friends. But if you are seeing it as some amount of partial tear, something which is just, missing from here, some fibers, then you can inject again PRP or dextrose, whatever you feel like. Then comes the, okay, what happened? I think my computer is about to hang. Okay. So then comes the median nerve entrapment. So median nerve can get entrapped from the Lesartus fibrosis. So what you will do, if you are seeing a patient who is coming to you with a pain in the elbow, and it is having mostly not in the around the elbow, but more he will be complaining of pain and tingling sensation in the 3.5 fingers. Okay. So if you are usually, when a patient comes to you with some elbow pathology, your 2 tests you will do, flexion and extension, and supination and pronation. So when you are doing the speed test, right, that you are flexing, if this is the upper limb, right? So you ask the patient to bring the palm towards his face, okay? And you apply the resistance. This is speed test. And this is for the biceps. But if this patient is, instead of, complaining of pain, he will say that I have got tingling sensation in my fingers. So you should think that it could be the Lisarter's fibrosis, which is thickened, and this patient is a patient of median nerve entrapment, right? At the Lisarter's fibrosis level. Then when you are testing the pronation, right, and you are applying the resistance, and again this patient is complaining of tingling sensation in 3.5 fingers, suggestive of median nerve entrapment in the in between the two heads of the pronator TVs. And some says like for the flexor digitorum superficialis, though we do not do a passive, the extension of the wrist, okay. But if you are doing it, right, here what I am doing, this is passive extension of the wrist. If I'm doing it, I'll be compressing the median nerve between these two heads of the flexor digitorum superficialis. So in that condition, if the patient is complaining of tingling sensation and the pain in 3.5 finger, it is suggestive of its entrapment by the fibrous band of your flexor digitorum superficialis. So a patient who is complaining of some elbow pain, but at the same time tingling sensation in 3.5 fingers, right? And there is one more thing, that is a sensation over the hypothenar eminence, which is supplied by the palmar cutaneous branch of the median nerve. Though I have not covered it because I thought I'll cover it during the carpal tunnel series. So just remember that if you want to test the proximal entrapment of the median nerve, so you need to go for a speed test. You need to go for a pronation against resistance. You need to go for an passive extension of the wrist along with in the extended elbow, right? So 3 tests if you are doing, and this patient is complaining of pain and tingling sensation in 3.5 fingers. So that is suggestive of a proximal entrapment neuropathy of the median nerve at elbow joint, okay? Then the cubital tunnel syndrome. So cubital tunnel syndrome, the patient who are sitting like this with flexed elbow, they are the one who are more prone for developing it. Now, when you're looking at the cubital tunnel, when you'll go back and you will see the recording again, you will see that we have not seen any kind of muscle, okay, when we are looking at the cubital tunnel. So you can have various pathologies. I've just tried to highlight some few that if you are able to see a muscle, you know, from where you're seeing the Osborn's ligament, there if you are seeing a muscle, very big muscle, then this is abnormal. This is not a normal thing. You are seeing something which is abnormal. So that will be Anconius epitroclarius, right? An accessory muscle. Usually we have the Anconius muscle from the olecranon process to the lateral epicondyle, right? We do not have it from the olecranon process to the medial. So it means there is something abnormal which we are seeing, right? So that could be one of the reasons for the cubital tunnel. We have various reasons. Since it's a joint, so you can have the osteophytes from the joint. You can have a ganglionic cyst. You can have even a lipoma, which is sitting there and compressing the ulnar nerve, right? So anything related to joints, you can have an arthritis of this joint where you'll be seeing the erosions. So all this can be the causative factor for the entrapment of the ulnar nerve in the cubital tunnel. So when you're putting a probe, see today we have scanned how exactly the normal things are. So instead of all this, if you are seeing something abnormal, you just try to find out what exactly is that. Now, this patient will be complaining of a pain which is radiating from the elbow to 1.5 fingers, right? You do a elbow flexion test. What you do here is this flex the elbow, and then you do the hyperextension of the wrist and ask the patient to hold this position for approximately a period of 15 to 20 seconds. If it is causing the tingling sensation in 1.5 finger, it is positive for your cubital tunnel. Then there are certain nerves which we have learned. We have learned that this ulnar nerve supplies the interosseous muscle. So how can you remember it? Is palmar interosseous, they are adductors. When you want to give blessing to people, your finger should be approximated, right? So palm, okay. So when your palm is in adduction, this palm means the palmar interosseous, they causes adduction, and the dorsal one, they causes the abduction, right? So in order to test the adduction function, we say this test as the card test. You give a card and ask the patient to just keep it between the two fingers and you try to take it off, right? If the patient is nicely, he is able to just give it back to you, then there is a problem with the palmar intraosseous, right? Then comes the testing of the dorsal intraosseous. So dorsal intraosseous, you ask the patient to move this middle finger towards the index finger and the little finger. If he is able to do so, the abductors are working well, means the dorsal intraosseous are working well. Then in order to test the lumbricals, right? Lumbricals will make a L shape. That is flexion at the metacarpophalangeal joint and extension at the finger. So it is like an L, right? So they are your interphalangeal joints and this is your metacarpophalangeal, right? So if opposite is happening, your interphalangeal joints, they are flexed and metacarpophalangeal joints are extended. We call this position as claw hand. Okay, that is also suggestive of ulnar nerve entrapment. Then comes the Froment sign. What is that? We have learned that the adductor, okay, pollicis is supplied by ulnar nerve. So what you will do, you will give one card to the patient and you will ask him, you will keep it like this, okay? And then you try to pull it back, okay? When you will try to pull it back, if the adductors are fine, he will maintain this position. If this adductor is not working well, we have tried to imitate this. So there will be a flexion at the interphalangeal joint. Why this will happen? It's because the FPL, which is supplied by the anterior intraosseous nerve, which causes the flexion of this joint, will come into play and this patient will try to keep the card back. So this is Froment sign, which is there for the ulnar, right? So I'm just, it's just a revision of what we have learned. Pain, which will be there, medial elbow radiating down to the dorsal as well as the palmar 1.5 fingers. Hypothenar muscles, obviously, the ulnar nerve it supplies, though I have not talked about it. So there'll be a weakness and atrophy of it. Lumbricals, claw hand, intraosseous, abductors you will test by Igawa, where you will move the thumb, where you will move the index finger. And adduction you will test by card test. And then sensory aspect, obviously, this supplies your 1.5 fingers. So you look for the sensation there. And this is very important because, you know, we from anesthesia background, we hardly read all this, but it is very important because cubital tunnel syndrome is the second. If you see after carpal tunnel, it is the cubital and then is the radial tunnel, which is very common, right? So diagnosis is obviously by history taking. You can order an NCV, you can order an EMG, but you have an ultrasound. Believe me, you will be able to diagnose it very well. If you have taken the history and then you put the probe and you try to look for it, you will be able to find the reason in most of the cases. And then, of course, if you do not have an ultrasound, you go for an MRI. Whenever nerve is, you know, entrapped, this is the proximal dilatation and this is the entrapment side. So this is how your nerve will look like in the long axis. And this is the nerve, ugly one, in the short axis. Okay. Now, we have just seen the dynamic examination of the ulnar nerve. Okay. So we have seen that it should always be lying close to the medial epicondyle. If it is not lying close to the medial epicondyle, if it is coming out of the medial epicondyle, but when you are just extending it, it goes back to the cubital tunnel. This is subluxation, where you can just suggest some, send this patient to the hand surgeon. They will be suggesting some exercise. And this usually they say that it improves over time. They don't operate when it is a subluxating one. But when you are just seeing the medial nerve, it has crossed the medial epicondyle and it has come over the common flexor tendon, then this is a dislocated nerve. I have seen one patient and he was a doctor only who has come all the way from Ratlam, and he was a medical student who was just writing, you know, mostly involved when he was just preparing for this MD. So he used to write, and every time he used to get the pain there, not even the tingling sensation. He has done all sort of MRI, nothing was there. But when we examined him, you know, under ultrasound, I tried to get that video today, but I could not. I don't know where I have saved it. But when I tried to go for a dynamic examination, every time it was, you know, coming out and it was sitting there. Many of the times it will go nicely, means it was not subluxation, it was not a dislocated also, it was in between that. right? So that also you will see. So this is the dislocated when it just comes out and it stays there itself. It doesn't go back when you are extending. So that is dislocated, and this nerve need to be repositioned. So here you can suggest a surgery. Many people, they do it at this also, but many people, they do not do it. But yes, we cannot help this patient. So it's always better to take the help. Then comes the joint. So this we have already learned that this fat pads, they are extra synovial and intracapsular. So if there is an effusion, always try to look for these fat pads. And if you are able to see a black halo beneath that, that is suggestive of a joint effusion. Instead of nice white line, if you are seeing something like this, this is suggestive of erosions. Erosions are typical of your inflammatory arthropathy. So you can very well say that you are seeing a patient of inflammatory arthropathy. Try to treat it systematically, not locally. Okay. So this is another example. This is trochleoulnar joint where you are able to see the fat pad, which is this effusion, which is pushing the fat pad up, right? Because they are intracapsular, but they are extra synovial. This is what I was trying to mean, that whenever you are looking at this recess, try to look for the fat pads, whether they are lying close, whether there is any halo, black thing beneath them, then that is suggestive of effusion. So effusion, you need to find out whether it's an inflammatory one or it's a degenerative one, and you can proceed it. If it's a degenerative, usually very less common, but inflammatory is more common. And then you need to find out whether it is because of rheumatoid or whether it is because of a seropositive arthropathy, and then you treat accordingly. So that finishes your topic for today. So
Madam, can you
yes,
please show Lacertus fibrosis, madam, on ultrasound?
Lacertus fibrosis on ultrasound. I will see. Let me call my volunteer if he has not gone. Any other question? माली एक बार राहुल को बुलाना. चेंज कर लिया क्या? ऐसे ही बुला दे, उसको ऊपर कर देंगे. He is coming, huh? This one. थोड़ा ऊपर लेट जाएगा. Who asked me this?
Lakshmi, madam.
Lakshmi, okay. Are you able to see my slides?
Yes, madam.
So that is your biceps. Okay.
Okay.
Got it?
Yes,
So
madam.
there is one tail of it. Okay, let me switch on the annotation. So whenever you are looking at the biceps, look for the tail of biceps. And the tail should be going medially. Okay, we were here. I'm not telling you the probe position. Probe is in short axis. Okay.
Okay,
So
madam.
now, if you are seeing it here, you just tilt it little more. So are you able to see an extension of those fibers which I have shown you, the tail? No. So this is your bicep. See the tail, how it is going. Okay.
Okay. Yes, madam.
So always try to look for this biceps and then look for the tail which is coming out from it. Now, in order to look, because you know, this is the biceps, it goes like this, na? So the way the anatomy is, you need to keep your probe also like that. So initially our probe was like this. Okay. But now, because the tendon, you know, the Lacertus fibrosis is something like this. So I need to tilt it, but how long I will tilt is like, you know, once this hyperechoic thing will be covering, will be forming the roof of the brachial artery and the median nerve. That's that
Okay.
much amount of tilt is fine. Otherwise, sometimes you get confused now, oh my God, how much I'm supposed to tilt? Like how I have done. I have just tried to look for that hyperechoic line, that hyperechoic thing, because they are the fibers. So those fibers will be forming the roof. Okay.
Yes, madam.
Now it is clear?
Yes, madam.
Okay. Any more questions from anyone to the pathology? Treatment.
Madam, in entrapment, we do only hydrodissection, madam.
Yes, we do hydrodissection. Oh, I have not told you that. Now, okay, yes, we do hydrodissection. You do it with 5% dextrose, because 5% dextrose, you can use even 10 to 15 ml. Okay, if this is the nerve, you go above the nerve, you go below the nerve. That's all. You make it free from that space. And because there is a rapid absorption of dextrose, it is not going to stay there. Dextrose, it's a normal body constituent. You can use it in a good amount, like 10 to 15 ml you can use, and it causes the inhibition of the peripheral nociceptors. I think I have taught you this in the basic class.
Yes, madam.
Okay, so it causes the inhibition of TRPV1 receptors, which are involved in peripheral nociception. So this is how it usually helps. And you can give, they says you can give weekly, week or two, and up to 3 to 6 injections you can give. Means this is how you can repeat it, and you can look for the improvement, how the patient is feeling now once you have done the intervention.
Means in 1 week, 2 injections, madam, like that 6
It
injections.
depends. That's what I'm saying. Now there is no guideline. So what you can do is 1 to 2 weeks gap between 2 injections. And how many you can give? 3 to 6 injections you can give. You got it? Means 2 injections. Either you can keep a gap of 1 week, or you can keep a gap of 2 weeks. That is up to you. If you ask me, I keep a gap of 15 days, because many of the times patient is not able to come within a week, right? They come from far place. It is not possible for them to visit me within a week. So I repeat it after 15 days. And how many injections you can give? You can give an injections 3 to 6 injections.
Yes, madam.
Okay.
So, ma'am, for this hydrodissection, we have to scan the mediana vena long axis view that you have shown, and then to find out where it is thickened, and then inject accordingly.
Yes.
Right.
First of all, find out if supposedly there is an enconeus epitrochlearis, which is sitting there. We are not going to help it. Send the patient for surgical thing, right? Because the nerve need to be repositioned, because this muscle, this is an extra thing. Again, it will be causing the entrapment, right? So better to take this muscle off. If there is a lipoma, there is no need to do the hydrodissection, right? So you need to send it to the surgery thing. If supposedly, I'm telling you, if it's a ganglionic cyst, you aspirate the ganglionic cyst. Inside the cyst, you inject the steroid, and then you do the hydrodissection. Your patient will be getting benefited, right? Why? Because you can treat the ganglionic cyst also, you can treat the nerve also. But in these two conditions where there is an additional, I should say, the muscle which is sitting there, obviously sooner or later this is gonna, again the vicious cycle will start now, because there is something which is abnormal which is there, so we need to take it off. It's always better to take it off rather than just doing the hydrodissections. But if patient is not willing, I don't want to go for surgery, you try hydrodissection. There is no harm.
Okay. Okay.
So any more questions? No questions?
Madam, last slide you showed bone erosions. What is the management?
See, bone erosions, what are the meaning is, you will not see a continuity in the bone. Okay. So like how the bone it has to be. Bone has to be hyperechoic and flat, right? Continuous. But instead of that, if some small things in the bone, if you are seeing, it means there is some kind of erosion which is going on, right? And usually the erosion, okay, I will show you, I think. You will be able to understand it better. Okay. Now see, this bone is nice. Okay. Very nice, hyperechoic. But do you think this radial head is normal? How I have showed you the radial head? You remember? It was something like this. Okay. But here, this radial head is not like that. It is something like this, as if something is happening to it, this bone. So these are basically the erosions. Erosions are very much common in rheumatoid arthritis. Okay. You do see it in other arthropathies also, but mostly they are associated with RA. That's what we say. Now you got it. What do we mean by erosions? Who asked me this? Not answering.
Yes,
How will
yes,
I
madam.
know?
Yes, madam.
Got
Yes,
it?
madam.
So
Yes,
whenever
madam.
you see the bone now, see that it is smooth like this. See, it is so smooth. You are looking at this bone. See this radial head and this radial head. Do you think they are same? No, they are not same. So I will erase the ink again and you have a look so that you don't forget. So this is normal radial head, but still it has got effusion. But this is abnormal, right? So this is how you see whether it is a normal one and whether it is an abnormal one.
Madam, management by
Management. See, management is like if it's a rheumatoid arthritis, obviously it's a systemic disease. You need to treat it systematically, right? You
Okay.
cannot just give injection in your elbow and you can say, okay, you go. No, because you need to have a systemic disease, a systemic treatment of the disease. So you better start the DMRDs, right? And usually I have a very good friend of mine who is like practicing along with me. So I send all my RA patients to him. I do not treat them because I already have my friend with me. So he usually then, starts the DMRDs and all. And that is the best, I think. But supposedly, where you can intervene, he has treated, but there is supposedly one joint, like knee, you take knee. It is having still the effusion and it is very painful for the patient. Then you can intervene. Then you can give local with steroid there. In case of inflammatory arthropathy, you can always give steroid. Okay. But now the trend is changing. People are going more towards HA because HA has also got in vitro studies have shown that HA has got inflammatory properties. And now they are also going towards the autologous serum. They say in coming few years, this is going to be a substitute of steroid. But since in RA, we give steroids, right? And that really helps the patient. So if it is an RA, if it is an inflammatory arthropathy, then it is no harm in injecting local with steroid in that joint. And always aspirate the fluid and send it for synovial, analysis. That is also very much required. But before giving steroid in such patients, try to rule out the infection. That patient should not be having any kind of fever. Means you are not treating a patient of septic arthritis, but yes, you are treating a patient of inflammatory arthropathy. That also you have to take care.
Madam, what is the meaning for medial epicondylitis? You said golfer's elbow.
See, these were the terms which were used if you have an inflammation of the common flexor tendon. Initially, they said, okay, it is golfer's elbow, right? Like when we will be teaching you knee, there are so many names which people have said, jumper's knee, runner's knee. So it is something like that. When you have a problem with the common flexor tendon, they have given a name that the people who are playing golfs are the one who are most commonly having this problem. So they gave it as a name as golfer's elbow. Then later on, they found that, okay, it is not only seen in people who are playing golf, but yes, we do see it in people who are playing even the tennis, even who are carpenters, who are plumbers, who are construction workers. So then they said, okay, this is not the right term. Let's call it as medial epicondylitis. Okay. Then they have taken the histological tissues, means the common flexor tendon, the histological tissue they have examined, and they see, oh, there is no inflammation. Then how can we label it as itis? Because itis means inflammation. Then they have seen that it is more of the degenerated phenomena which is going on inside the cells. So they said that it is better to call it as common flexor tendinopathy, or it's always better to call it as epicondylgia. And even you can call it as medial elbow tendinosis. That is also absolutely right. Now you got it?
Yeah, yeah.
Madam, point where we should give the inject PRP or dextrose, madam, in the tendon, flexor tendon or extensor
Flexor
tendon.
tendon, if this is the, what to say, the medial epicondyle, you have the bird beak appearance now, there you give.
Madam.
And it's always better. See, when you have an ultrasound now, you know which is the hypoechoic area. I would suggest not to learn it in this manner, but to learn it. Suppose if it's a diffused, like we have seen it in the pathology slide, when you go back to the, what to say, the recordings, you see it. I have shown you, if it is a diffuse, then you can give it anywhere, right?
Okay,
But if it's a focal area of tendinosis, try to stick to your needle to that area only. Okay, because there is no point in putting your needle where you are seeing the normal tendinous tissue, right? So try to look for that focal zone where it is. in the tendon is always hyperechoic fibrillar. If you are not able to see the hyperechoic fibrillar pattern, if you are able to see an hypoechoic area in that white thing, so target that hypoechoic area. Just keep this very simple in your mind. So you will never be wrong, I'm telling you. Okay.
Okay, madam. Madam, in ulnar neuritis, we give only hydrodissection or steroid
Even
also.
yeah, but now see, people, they in the initial days and all, like people now also they are using NSAIDs, they are giving even the systemic steroids, right? But I am not in favor of that. I usually do hydrodissection if I'm seeing something like that. I feel it really helps and there is no harm.
Yes, madam.
Systemic steroids, so many harmful effects. One of my friend has developed bilateral, so I have done bilateral for her.
Madam, what
And
is the
you know,
most,
it's yes.
madam, in your practice, what is the most common elbow injury you see in sports, madam?
No, elbow sports, it is the tennis elbow. Okay. Again, I'm saying tennis elbow so that you are familiar with it, but we no longer call it. Medial is very less common as compared to the lateral one. When it comes to tendinopathy, it is more commonly the lateral, not the medial. And when it comes to the ligament injury, yes, in the sports people, you have this anterior band of the ulnar collateral ligament injured more as compared to the lateral ligaments. So it is different, you know, the tendons are different and the ligament is different. Because when you play like this, people who are throwing like this, so that is the valgus stress we are giving. So this ligament will go.
Okay.
And many of this posterior, because I'm not supposed to talk about it, posterior lateral injury now they have already done because they usually do not come to us. They like lateral ulnar collateral ligament, which is there on the lateral side. They get an MRI done and it is a surgeon who is treating them. If your surgeon is a good friend, he will send it to you. Otherwise, they themselves will be treating. So medial, you will see more the ligament, but tendons, it is more the lateral which you will see, not the medial. Okay, no more questions?
Ma'am, I have a request. Actually, my connection dropped in between. So can you repeat that pathophysiology part of the golfer's elbow or common flexor and epicondylitis?
You watch the recordings if it is
Yeah.
feasible. Okay.
Yeah.
And still, if
I
you
actually
have
forgot
any,
that part.
yeah. So you watch the recording, but still, if
Yes,
you
ma'am.
feel that you have not understood, you let me know in the next class. I will show you. Okay. Again,
Yeah,
usually,
sure.
like briefly, I will tell you the tendons,
Yes,
they
ma'am.
are having a parallel arrangement. When you are subjecting the tendon to injury, there is no longer the
Mhm.
fibrillar pattern. They are having wavy patterns then. Now,
Yes, ma'am.
suppose again you are not taking care of it, then what happens? The angiofibroblastic hyperplasia. This we have read during our anatomy days. Okay, the inflammatory, the
Mhm.
stages will come. So what will happen? After that, you will be having the activation of the enzymes, which will be causing the breakdown of the collagen fiber. So that is the partial tear stage. And later on also, if you are not taking care, whole of the fibers will break. So that is full thickness tear. So some fibers breaking, that is partial tear. If they are becoming, angiofibroblastic stage, because when you put the color Doppler, if there is a tendinosis, it is taking up, means the blood vessels are going in order to heal the tendon. So that is still in the healing phase, right? So this
Yes,
is
ma'am.
your tendinosis stage, and that will be corresponding to grade 2. Grade 1 is tenosynovitis, where you have just the wavy pattern. So that's the reason in a tenosynovitis stage, if you see, it is always the rest, anti-inflammatory, because the body will heal ultimately if you will give rest to the tendon. That is what is the means the theory behind it. And if it is not healing with the conservative, then it's your role which comes in and you inject. So if it's in tenosynovitis stage, you can give steroid. If your patient is very much eager, I want immediate relief, but never ever give steroid inside the tendon. Because if you will give steroid inside the tendon, it will cause the breakdown of the collagen fibers and you will be gifting a tear to the patient. Okay. So if you are injecting the steroid, so if this is a tendon, okay, so your steroid should be above my this hand, right hand. But if you are injecting PRP or dextrose, it should be within the tendon. Okay.
And any tips like about increasing this needle visibility during shoulder. Actually, I did one hydrodilatation, so I was able to go inside, but I was not very happy with the needle tracing.
See, needle, I would say that try to, first of all, you should have that orientation, okay? Because
Yes,
always
ma'am.
remember that I'll show you. This is the probe, okay? So
Yes,
this
ma'am.
probe, you can imagine, this is the footprint, right? It is so small, isn't it? So if your needle is here, means within this footprint, you will be able to see it, right? But if my
Yes, ma'am.
needle is here, there is no beam to see it. If my needle is here, there is no beam to see it. So first, very important thing is always try to align. Okay, let me remove the background. Okay. So if this is the probe, if my needle is here, I will not see. So try to, first of all, this is a different probe. See, you have a dot here, right? So that is the central portion. You try to keep your needle here. Once you puncture, you try to keep it here. And never ever take so much of acute angle, because if you will take acute angle, it will not go. See? Okay, beam will not go. Try to keep the angle, if this is your probe beam which is going, and if you make an angle here, so you try to keep it 30 degree, something like that, so that if you have to go, you can use it. Then you can use the heel toe maneuver. Suppose sometimes you have taken a prick here, then what you can do, you tilt your probe like this. So if you will tilt your probe like this, you know where is your needle. Okay. So you can
Right, ma'am.
use this maneuver also. You have pricked it, but your pricked is wrong. Tilt it like this. So you will see your needle now. Okay. So that is
Right,
going
ma'am.
to help you. Where is your needle? Second thing is, same way, this is heel toe. Another one is skying. Means if you have put your needle like this, you can tilt it like this also. So you will see where is your needle. So you need to learn this maneuvers when you are doing an intervention. Slide it up, down, means keep your needle in place and try to look for your needle if you have wrongly done it anywhere else. And what I usually do is I spread local to a very long area. If this is the probe, approximately 1 to 1.5 centimeter away from it, I give a very nice local. So supposedly my prick is not in the right direction or something has happened. So I can always change the prick. Okay. And once you put the needle, you just once the moment you cross the subcutaneous plane, right? And then only you go more deep. Otherwise, what people are doing, they'll just go full deep and they'll try to look with the probe. And then the patient will be like, it is paining, it is paining. So that you don't do. Second thing is, before doing a procedure, you put the needle in, I should say, just apply some amount of distilled water over it. Because if there is water bubbles now, this will also increase the visibility. And nowadays, like my machine has got a software, needle enhancing software. So newer machines have got that software also where they will be enhancing. Try to use the echogenic needles if possible, wherever it is possible, I should say. And the third thing is always go for hydrodilation, hydrodissection with 0.5 ml of normal saline just to look for the tip. And always remember, when you are going inside, the bevel has to be up so that you see two things, one white line up and one small white line down. So you know that this is the tip. Okay, so two white lines you will see. So that is going to be your tip, bevel up. And once you are reaching, you can turn the bevel down. That is also one of the very important things which we should do.
Yes, ma'am.
And
well,
rest comes with practice.
yes, ma'am. I hope we learn it fast.
We will learn. Even I have learned, so anybody can learn. That's what I feel. Yes.
Um, when we try to reduce the angle of the needle, we need to go a bit more away from the probe, right? In that case, when we are trying to go inside your shoulder joint, so is there any possibility that a needle might hit the tendon of infraspinatus?
I'll tell you what you can do in that condition. Suppose you have to go in acute condition, matlab acute angle you want to go, right? So what you do, you lift your probe, okay? Put your needle here. Means you take a prick here, and then you put your needle. Then you put your probe. Means this is your probe. I have to go in this direction. Exactly. So what I will do, I will lift it, I will put my needle and then I'll put my probe and I can go. Acute angle also you can go. See, exactly from the probe if you will go. This is how usually will be for the glenohumeral joint. I usually do this.
Yes, ma'am.
Means I take a prick very close to the probe, but I lift this angle and then I put my probe and then I put the needle. Then I put the needle a little bit and then I put the probe. So this is exactly in line. See, and if I will go, I will reach the midpoint. See,
Yes, ma'am.
this you can do.
Yes, ma'am. Right.
It will be
Thank you
easy.
so much, ma'am. Yes,
You will
ma'am.
learn this, by what to say, doing, all the maneuvers. First of all, learn all the maneuvers and do whatever is good according to you.
Yes, ma'am. Yes, ma'am.
Any more questions, or we can say goodbye for today? And we'll meet up in the next class. Till then, keep reading and do scan, because scanning is more important, right? Unless you will scan, it's difficult, but if you will scan with the class, you will remember it because it's just fresh in your mind. So go back, listen to the recording, take a machine and keep on scanning, because you will remember it then throughout, I'm telling you. And do remember it with the mnemonics, which I have taught you. You will never go wrong. Okay, no more questions then. Take care. Good night. And I hope you enjoyed the class. And somebody was asking about the annotation today. I thought, now I'm sure you won't be having any problem when you will be seeing the structures. Is he there or he has left? Okay, might be he has left. Okay. Good night then.